Thank you everyone for joining us for the webinar today. We're going to be talking about can women afford emergency contraceptive pills, and we have a really exciting lineup. Before we get started, I wanted to see if everyone can just go ahead and mute their lines. This is Anita Deshpande from the Reproductive Health Supplies Coalition, and it looks like we have quite a good group on the phone today. So I will go over the agenda for you. Today we'll have presentations from Denise Harrison at USAID. She's going to be talking about the total market approach and setting up a framework for the rest of our discussion. Why do all the various sectors matter, and especially why do they matter for the market in emergency contraception and contraceptive access? Then we'll have Elizabeth Westley from the International Consortium for Emergency Contraception talk about the results of their Innovation Fund project, which was a global study on the price of emergency contraceptives in the commercial sector. And that will be followed by a presentation from Sarah Ridge, also from ICEC, and she'll be talking about case studies in DRC and Nigeria on this very same issue. So with that, I think we'll go ahead and get started. And I will ask everyone one more time, just go ahead and mute your lines if you've just joined, and then we will jump into the presentation from Denise.
I'm Denise Harrison, and I'm the Senior Market Development Advisor in USAID's Office of Population and Reproductive Health, or PRH, in the Commodities, Security, and Logistics, or CSL division. So I was asked to provide a brief introduction for this webinar using my commentary on healthy contraceptive markets recently published in the journal Contraception, and the total market approach, or TMA, to frame the discussion. I want to point out that my commentary is my own opinion based on working in family planning and reproductive health in the public, NGO, social marketing, and commercial sector for more than 15 years, and not necessarily USAID's opinion. However, my statements about what TMA is are based on USAID's thinking and statements on TMA. So, it's all about women. Creating healthy markets for emergency contraceptives and other modern methods of contraception means ultimately putting women first and thinking about what are their needs. It is only by starting with the woman or client and understanding what her needs and wants are that we can achieve FP 2020 goals, sustain them, and grow them. To put women first and meet their needs and wants means leveraging the strengths of all sectors, public, NGO, social marketing, and the commercial private sector, and taking a more business approach. It implies taking the perspective of all sectors to optimize public and private resources. If we only take the perspective of the donor or funder, we jeopardize sustainability as well as choice, and more importantly, we do not meet women's needs. So TMA is one of 5 key focal areas for USAID's PRH office. Quoting from the TMA briefer, TMA is operational when you have a fully rational and efficiently segmented market where all sexually active men and women have geographic, administrative, informational, economic, and psychosocial access to a full range of voluntary affordable family planning products and services. The TMA aims to ensure best use of the available resources by strategically engaging each and every actor that has a stake in the provision of information, products, and services in reaching market segments. Consumer choice is an important value prioritized by TMA. So, going back to my commentary, using a long-established fundamental marketing framework developed decades ago of 4 Ps and 4 Cs, and if you are an RHSC MDA member, I'm sure you already know what 4 Ps and 4 Cs are, but just a refresher: product, price, placement, and promotion, and the 4 Cs are customer, cost, convenience, and communications. So in using this framework, we can see if we are meeting women's needs and look for the signs of a healthy market. And I just want to highlight some of these signs that are in my commentary, and I think it's already been circulated. And these key signs include the availability of a wide range of contraceptive methods and quality products and brands, as well as an innovative pipeline. Another sign is incentives in place for a wide choice of contraceptives and consistent availability. The availability of financing options, allowing women to obtain the method, product, and brand that is best for them. Convenient, private, retail, and public sector outlets with readily available trained personnel. And the last sign I'll highlight is culturally appropriate, market-tested outreach for branded and generic products implemented regionally and globally. So these are key signs of a healthy contraceptive market. My colleagues Elizabeth Wesley and Sarah Rich will now continue the webinar looking at the market for EC and focusing specifically on price and affordability. Thank you.
Thank you, Denise.
Thank you so much, Denise. That was terrific. Okay, let's get these slides advanced. Hang on. So as Denise said, and just as some background, the reason why in ICEC and for emergency contraception markets, why we focus so much on the private commercial sector is that it's really the most, it's been the most effective sector at getting emergency contraceptive products out there. So when we scan the data, we find that social marketing programs, only about a third of family planning social marketing programs have an EC product in their portfolio, and about half of developing country public sector programs include an EC product. So for this product, we really are counting on the private commercial sector to make EC available through pharmacy sales. So we've always been very interested in that aspect. But how well is that sector doing in terms of meeting the needs of women for an affordable, high-quality product? And I'm quoting someone who's actually on our webinar right now, who's anonymous, that, you know, the issue of affordability is a key one, and one that we probably don't talk about very much in our field. So I just want to put some caveats out there for our hardcore researchers. We got, as I explained in my acknowledgement slide, we kind of crowdsourced this data collection process. So for some countries, we had only one person send us prices. For some countries, we had 5 or 6 or 8. So we had to work with the data that we had, and we used averages. We averaged the lowest price, and we averaged the highest price. So this is not a rigorous national survey. It's really intended to give us a wide number of countries rather than deep information about specific countries. Because of the, you know, who is on our distribution list, we know that most of the data would have come from capital cities, just because we're reaching people who are distributors, NGO managers, Ministry of Health folks, and those would tend to be clustered in capital cities. And I'm not going to present here on our data from the U.S. and Europe. So these are our methods. We sent out, as I mentioned, our survey went out in 3 languages. We did 2 rounds of surveys. We did a first round and found that the data that we were getting, it was kind of a, if you go to the first pharmacy, blah, 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 and then check here for the next pharmacy, and it was extremely complex. I think it was probably hard for people to fill in, and it was certainly hard for us to figure out how to analyze it. So we simplified that and sent it out, and I would say more of our data came from the second, more simple survey. But that is definitely a methodological issue that we used 2 different surveys with, you know, the same key questions. And we asked the folks who filled in the survey for the highest price method that they found and the lowest price method. This analysis will focus on levonorgestrel. We did ask people to identify if it was a UPA, a ulipristal acetate product, which is available in an increasing number of developing countries, or levonorgestrel. But most of our data was on the levonorgestrel EC pills, and that's what our data focuses on. We pulled out the UPA data to the side. And then we augmented the pricing data that we got with data from our country database, which I'm hoping most of you are familiar with. We have in emergencycontraception.org, we have a country-by-country database where we have information on, is there an EC product in the public sector, the social marketing sector, is there a locally manufactured product, and so on. Okay. I'm hoping that person can mute themselves. We received data from 72 countries. We picked a specific day, I think it was like August 15th last year, to do the currency conversion to U.S. dollar values. And then we did something that I think is a little questionable. We wanted a global way to compare affordability, and there's some good data in certain regions. Europe has really good data on, for instance, average monthly wage or average weekly wage. We could not get that on a global level. The only global economic indicator that we could find, and we actually really asked around about this, was GDP per capita. So we used GDP per capita data and divided it by 52. We divided it by 12, and we divided it by 52 to look at sort of what would be average weekly income. Obviously, that's problematic in a lot of ways because GDP doesn't necessarily reflect what is in the pockets of common people. It could be very skewed if there's a lot of income coming in, through oil companies or mining companies that might concentrate in the hands of a very few people in the country. So it's a difficult indicator to get. So I'm just going to share some prices that we found. So you'll see the average, the lowest, this would be the lowest price that was reported average. So if 3 people from the Democratic Republic of the Congo reported, we took the average of their lowest prices. So all of this is about the lowest price. And then this is the GDP per capita in the next column, and you'll see there's quite a range. So if you look at the difference between DRC and Ethiopia are similar, but Nigeria, for instance, is much higher. Kenya is somewhat higher as well. And you'll see there's really an interaction between the dollar price and the GDP, and that gets us to the column all the way to the right, which is the percentage of your, quote, weekly income that you would need to spend to buy one package of emergency contraceptive pills, knowing that there's all kinds of caveats and problems with that data. You can see a huge range. So when you combine, for instance, a very high price in the pharmacy in, for instance, Guinea or Mali or Mozambique, with as well a low GDP, it really compounds so that, in Guinea, for instance, you would have to spend 70% of your average weekly income to buy one pack of emergency contraceptive pills. I'll show some data from some other regions. We have all of this. I just picked a few countries so as not to overwhelm you with huge charts with tiny, tiny numbers. And you can see quite a difference in the GDP, obviously, in Latin America. And then here's some Asia prices. And you'll see the prices are much, much lower. So if you look here in Latin America at the prices and then you look at the prices in Asia, you'll see very, very low U.S. dollar prices in Asia. And I'll talk about why that is. So all that data that I just showed you in the charts, here it is in the bar chart. And so this is the median percentage weekly income for that lowest cost product in the private sector relative to the GDP per capita. So the red bars, you'll see Africa, Latin America, and Asia are red. And you'll see Africa, the median weekly income is 14%. And then we decided so that's quite different if you look at Africa, Latin America, and Asia. And then we decided to break it down and reanalyze it by region because we were noticing these much higher prices in the Francophone countries. And so you'll see Francophone Africa as a subregion has the highest prices, and then Southeast Asia is very low. And Asia as a whole is very low. So then we ran all kinds of analyses, and our consultant Heidi Jones helped us with all of the complex analyses on this, and we really tried to figure out what is driving these big differences that you're seeing. And the only really, really strong factor was that it was a locally manufactured product. And I think if you put in Europe and the U.S., this would have really changed the analysis because I think in Europe and the U.S., the markets are very different, and there's a lot of impact of sort of insurance and other factors. But for these regions, the locally manufactured product had the biggest impact, and that was of the highest significance. And of course, as I think most of us know, Africa doesn't have any local hormone manufacturing at this point. And another weaker but also significant association was if there is a socially marketed product available. And we were unable to pull out, if a price was sent to us, would this be socially marketed, for instance, a post-tenor that was socially marketed or a post-tenor that was in the purely private commercial sector. We wouldn't be able to know from the data that we got. So we did see an association of countries where we know that there is a socially marketed EC product, but that in general resulted in lower prices. The public sector availability, you would think that in pure market forces, maybe a public sector product might drive down the prices in the commercial sector because women could go and get a subsidized or free product in the public sector. We did not find that to be the case. Maybe that means that the emergency contraception user is not really price comparing between the public and the private sectors. We have always heard that there's a very high preference for pharmacies and for the private sector access for this product. And clearly African women are paying more than women in other regions. That's just absolutely clear. And here's a little bit, I was talking about the availability. So the red bars are if there's a locally manufactured product, and you can see that a lot of Asian countries and Latin American countries have a locally manufactured product, and Africa has zero. And a lot of African countries have a public sector product, interestingly enough, fewer in Asia. So that is, I think, part of why we're seeing that the data, the prices weren't really lowered by the availability of a public sector EC product. So this is really from our database about the percentage of countries that have EC products available through these different sectors. Okay, so this is kind of our final results, and these are some products from Nigeria. I think our manufacturers on the line may recognize some of their products. And it's really that after we did the statistical and the adjustment for all these factors, local product availability, social marketing, and public sector products, the Africa region had much more sort of unaffordable prices than Asia, and that was our strongest statistical result. And here is the same data in a map, and you can see those dark countries are sort of clustered around Central and West Africa. The U.S. didn't come out as totally terrific either. And so these are our conclusions. In many of the countries, we did note that EC products are expensive as a proportion of income. But at the same time, affordability is really influenced by GDP as well as price. So it's not only bringing in a lower priced product, but also, unfortunately, and a little bit out of our hands, is that a lot of countries where we were gathering data just have very, very low incomes. And so that really is factoring into affordability as well. As I mentioned, the Francophone and Lusophone African countries had the most expensive products, followed by Central America. Central America was quite different from South America. We also found a lot of changes, even in the 18 months of this study, a lot of new products coming in, a lot of very dynamic market for emergency contraception. And our conclusion is that obviously the private commercial sector remains really a very important source of ECPs for women in developing countries. And that is my conclusion. I'll move on to Sarah.
Great. Thank you so much, Elizabeth. I'm Sarah Rich, and I also work with Elizabeth at the International Consortium for Emergency Contraception. I'm going to be presenting some more in-depth results that we found in two countries, in Nigeria and the Democratic Republic of the Congo. This is all part of the same study. Elizabeth presented on our global results, and I'll be presenting a bit on what we found at the country level in these two countries. There we go. So I'll talk a little bit in a minute about why we chose those two countries, but I'll start by reviewing the methodology that we used in order to gather information in both Nigeria and in the Democratic Republic of the Congo. We undertook many interviews with key informants from across all of the sectors that are providing emergency contraception. So we spoke with private sector manufacturers that are providing a lot of product in both of these two countries. We also spoke with all of the social marketing partners in both Nigeria and in DRC that are providing emergency contraception. We spoke with Ministry of Health officials and also with civil society representatives. And as Elizabeth mentioned, ICEC has a database, a country-level database with data that we pull from a number of sources. And in developing these case studies, we really relied on a number of those data sources, including AccessRH, the Contraceptive Security Indicators from USAID and Deliver, Contraceptive Social Marketing Statistics, and in Nigeria, the Measurement, Learning, and Evaluation Project for the Urban Reproductive Health Initiative. We also conducted a small number of informal pharmacy visits in the capital cities of both of these two countries. So this map, this is the same map that Elizabeth showed, and I've just circled the two countries that we chose for our case studies, Nigeria and DRC. The first criteria for selecting our country case studies was whether or not we had all of the data that we needed in order to understand what was going on with the markets there. So did we have the pricing data? Did we have the programmatic data about whether EC was being distributed in the social marketing sector and the public sector? And then from there, we wanted to select countries that had different markets for emergency contraception. And this map highlights this just a bit. You can see that Nigeria is the light pink color and DRC is the dark purple color, which means that in Nigeria, EC is more affordable in terms of how much of a woman's weekly income she has to spend in order to purchase EC relative to DRC, where she has to spend more than 20% of her weekly income. Those affordability measures depend both on how much the product costs as well as how much money people have to spend. So here I'm just highlighting for you to give some further context that in the DRC, in US dollars, the product cost $2, and in Nigeria it cost about 50 cents, so it was more expensive in the DRC. And DRC also has lower GDP per capita as of 2013, about $454 versus Nigeria's 3,006. We know that GDP per capita always masks lots of differences in income across the poverty spectrum, but this was the best measure that we were able to use, as Elizabeth explained. So with both of these two factors, this really contributed to a much higher relative price in the DRC versus in Nigeria. I'll start by talking about the results of our case study in Nigeria, and then I'll turn to our case study in the DRC. In general, Nigeria has a relatively robust market for emergency contraception compared with other countries in the region. There are strong social marketing programs that are selling EC primarily through private pharmacies and drug shops, so not exclusively. Society for Family Health, which is an independent affiliate of PSI, has been distributing emergency contraception for more than 10 years in Nigeria, and they sell Postanor 2, which you can see in this photo, which is purchased from Gideon Richter, one of the major manufacturers of emergency contraception worldwide. They've also done some sales of another EC product, Pregnon, a generic purchased from ZamiCare International. In addition, DKT Nigeria launched a new EC product, PostPill, which is also in this photo here, in April 2015, and this was launched at a lower price point than Postanor 2. So both of these socially marketed products are generally available, as I said, at private pharmacies and drug shops. But also at these private pharmacies and drug shops, we saw other products available. Here in the photo, you can see one called Sendanor. We also found several other products. We So these are some generic products that have entered the market, particularly in the past few years as demand has exceeded supply of the other EC products that were available. And we just don't know very much about the quality of these products. It's not to say that they're not high-quality products. We don't have data or information about those, so that's sort of a lingering question. We do also know that the Nigerian EC market, as well as its drug market more broadly, has some issues with counterfeit products. And in 2013, the Nigerian Food and Drug Administration did issue a warning about counterfeit emergency contraception and did 3 recoveries of emergency contraception, I think, from the Lagos airport. In putting this together with the social marketing sector and the private sector, what does access in pharmacies and drug shops look like across Nigeria? We know that it varies by city. So looking at some of the data from the Measurement, Learning, and Evaluation Project, which surveyed pharmacies and drug shops across 6 different cities, we just see very different levels of EC supplies and availability across these 6 cities. Some pharmacies and patent medicine stores in some of the cities were much more likely to say that they ever stock EC, and we're also more likely to have it in stock than in other cities. Outside of cities, we don't have a lot of data, so we really don't know what the private pharmacy and drug shop access to EC looks like outside of urban areas. In the public sector in Nigeria's public sector does not procure or distribute any emergency contraception, so you can't get emergency contraception in any public health facilities. Now, in a country like Nigeria, where we see from the last slide that there is private sector and social marketing availability of emergency contraception, what does it mean to not have a public sector product? So we think that this comes down to creating barriers to access for a few particular groups of women. One, and very importantly, is women who have been sexually assaulted and come into a public hospital or another public health facility seeking seeking treatment. They wouldn't be able to get emergency contraception at those facilities, which of course puts them at much higher risk for pregnancy following sexual assault. We also heard from many stakeholders that even though the relative price of EC in Nigeria is lower than in many other countries in the region, price is still a barrier for low-income women who may not be able to afford emergency contraception from the private sector. So if it's not available free of charge in the public sector, some of these women might have a barrier in obtaining emergency contraception because of the price. We also heard, particularly from our social marketing partners, that the security challenges in the northeastern part of the country make it very difficult to provide products there. There might be some products there, but in general, it's just not possible to have the same level of distribution in this area of the country. And finally, as I mentioned before, we really don't know what access to EC looks like for rural women in private pharmacies. So this may be another area that public sector availability is critical. Moving to the DRC, we see a very different market for emergency contraception in the DRC, and I want to start by highlighting a few sort of cross-cutting themes that emerged. One is that there are really substantial supply chain challenges across the DRC. Infrastructure and transportation challenges make it difficult across all of the different sectors to transport goods and ensure availability widespread. We also found that across all of the partners, EC was really associated with sexual assault specifically in the DRC. So it wasn't necessarily thought of as a product for a woman who had unprotected sex, but it wasn't sexual assault. And partners especially pointed to the UN Minimum Initial Service Package kits, which are these humanitarian kits that are provided in humanitarian settings. And these kits are particularly available in the eastern part of the country where there are many humanitarian organizations working because there's still ongoing conflict. And finally, I'll note that both UNFPA and USAID procure EC in the DRC for both the public and the social marketing sector, so that affects multiple sectors. looking across these sectors in the DRC and what does availability of EC look like. In the public sector facilities can provide EC. The government, through UNFPA and USAID is procuring EC, and it can be provided in public sector clinics, but the access level is unclear. We do need more data on this. We visited one public sector facility in Kinshasa, and they did not have any EC in stock, but of course that's only one visit, so it would be great to have more data on that. The social marketing sector in DRC is also active on emergency contraception, but the programs are significantly smaller. DKT just recently registered and launched an EC product, and PSI has been distributing EC through its social franchising network and private pharmacies, but it's in lower quantities than we see in Nigeria and some other countries where the social marketing sector has been really strong on providing EC. This might be, this is to date, both of these social marketing organizations are continuing to work in DRC. And just like in Nigeria, those products tend to be available in private pharmacies and private drug shops, where we also saw other generic emergency contraceptive products available. On this slide, you can see one called Pilule S on my prior slide. But again, as with Nigeria, the quality of these products is unknown. They might be great quality, but we don't have any information. So access outside of Kinshasa, which is where Elizabeth and I focus most of our work, is really a big question mark for us given the big supply chain issues that the country faces. And even within Kinshasa, we have some questions about how accessible EC is for low-income women, given that it's not available, given that the level of availability in the public sector seems to be unknown. And we also visited 5 pharmacies, and 4 of them had emergency contraceptive products, but the one that didn't was in a lower-income neighborhood. So looking across these 2 case studies and also looking back at the data that Elizabeth presented on global affordability of emergency contraception, we've developed a short list of recommendations for developing a total market approach to emergency contraception at the global level. So our recommendations include supporting the social marketing sector to invest in EC in new countries, but also to expand their EC programs in countries where they are already where they're already working. A second critical piece is focusing on the quality of the products on the market, particularly in the private sector market, where we know a lot of women are accessing emergency contraception. Third, even in settings in which we see active private and social marketing work on emergency contraception, the public sector still has a critical role to play in ensuring access to EC for low-income women, for rural women, and for sexual assault survivors. And finally, I just want to note that with thinking about the total market approach for EC, it's also critical to pair these efforts with demand generation and raising women's knowledge of emergency contraception. Women's knowledge of EC remains very low in many countries. It's much higher in Nigeria at about 30% than in DRC, but it's still the majority of women have never heard of emergency contraception. So thinking about availability of emergency contraception and how to improve availability, we would also need to be looking at the other side of that and making sure that women have heard of EC. Thank you so much. That's the end of my slideshow, and I think that we're all very open to hearing your questions and thoughts.
Thank you. That was really a very interesting presentation from all of the speakers. I will now open the floor to everyone for questions, and all of you.
The conference has been unmuted.
Everyone should be able to unmute themselves and ask their questions. So if you'll just go ahead and jump in, introduce yourself, and then ask the question.
Hi, my name is Deepa Rajamani. Thank you for the great presentations, Denise, Elizabeth, and Sarah. Very informative. My question is to Sarah and Elizabeth particularly. This is on the affordability calculations that you're talking about. I'm curious to know if you assessed affordability by sector for EC.
Yeah, I can speak to that. So because of the way that we gathered our data, and actually we also have a similar question from Mr. Mwebembezi from Uganda about our methodology. So we basically took the lowest price in the private commercial sector because of how we collected our data. So because we were using a crowdsourcing approach and we got data from 74 countries, we didn't have the possibility of going to each country or hiring a consultant for each country to go and assess the price in the public sector, the private commercial sector, social marketing sector. We were unable to differentiate between a socially marketed or a purely private commercial sector in the marketplace. Often you can't tell. So the people who went out to a pharmacy and asked, what the different prices were, wouldn't necessarily be able to know in some settings if that was a socially marketed or a commercially available product. In some cases, you might see a little DKT brand on the corner, but that's not universally the case. So I think that would be a really interesting and a different study to do, would be maybe to pick a smaller number of countries and to do kind of a cross-sector analysis. But that was not what we did in this study. But I think it would be great. It would be a great idea for another innovation grant.
Thank you. There's another quick follow-up question, Elizabeth. This is again related to affordability. You mentioned that you use the weekly income as percentage of GDP. This income, was it characteristic of the lowest paid worker, an unskilled worker, or what sort of income did it characterize?
So as I pointed out in my caveat slide, I don't know if we can go back to that. The only way that we were let me see, I'll pull this up. The only globally comparable indicator that we were able to find that was really that we could get for Latin America and for Africa and for Asia was GDP. So it's very crude. It is GDP divided by 52. So in some countries we were able to look, there's data that's more available by quintile, and that would have been great. There's also data for some countries that would have been very useful on like the average wage of a public sector worker, that we also had a suggestion to look at that. But unless we could get it for all the countries for the same year, we really couldn't use it, because we wanted, the goal of this study was to have this cross-country kind of global comparability. So I think there's a lot of different ways to look at affordability. We had to, because of the kind of breadth of the study with the different countries, we were forced to use a pretty crude indicator. But I think you could go in, and I think PSI might be doing some work on this, and Denise actually knows a lot about this, but there's a lot of more in-depth single country market studies where they're looking at a wider range of facilities, and also maybe a deeper look at affordability by quintile and by sort of rural, urban. We were not able to do any of that deeper analysis. So really the goal of our study was this sort of regional, sub-regional, and kind of national differences.
Okay. Yeah, there is a WHO price tracking survey guideline as well, which talks about affordability from a different angle as well. Yeah.
It wasn't all the countries, so that was, But there's definitely many, many different ways that you can look at this. And I think there would be, you could get a lot more subtle data by going to maybe 2 or 3 countries and spending more time.
Right. Thank you so much.
Oh, you're welcome. And could I just did that address Justice's question as well that he sent in via the chat? Hopefully.
Yes, please. Here I am.
Okay. Did that address your question about the sample size? So the sample size was different in different countries in terms of the number of pharmacies that were approached.
Excuse me, could you repeat this question?
So there was a question that came in via the chat, which was, how did you select the sample size? And the answer is that we got different amounts of data submitted from different countries. So in some countries, we only had data submitted from one informant, and I think the most that we got might have been 8. I think that was maybe Nigeria. So the sample size did vary from country to country, and so we used an average.
Great.
And actually, because we asked people to submit their email address, so if we saw a number that just looked really strange, we actually corresponded with the person who submitted it. And sometimes it was just, a digit, what's it called, decimal point in the wrong place. So we did kind of check. It was a small enough study that we actually checked kind of point by point by point.
Actually, do you want to ask this from me? I'm from Gideon Richter, but we don't have detailed information about these countries. Unfortunately, we are in contact with the local distributor, with the local NGO, but that's all. We don't receive any feedback from their activities. This is the problem. Somebody already mentioned that we cannot follow up where our products will end, on the public sector or on the social marketing on the private sector. So we miss even this basic information from these countries where we sell these ECs, the Postinor 2, namely.
Thank you for that.
I think that was a really good point from our manufacturer, and we did speak with Gideon Richter and some other manufacturers. And as I said in my final slide, I think it's a very dynamic market. And so a comment that we heard from a number of people was the price that the manufacturer thinks they're selling or the distributor thinks they're selling isn't necessarily the price that ends up on the sticker on the box in the pharmacy. Because obviously people who own pharmacies are business owners, and so the price can be quite dynamic.
Yeah, exactly, and we don't have information about the selling price as well. There is an agreement between WHO and between Richter about the selling price. We keep the selling price, the agreed price, only for the NGOs like UNFPA, like PSI, like GSI, like USAID, and so on. But for us totally unknown NGOs, we cannot keep this price. This can cause a big difference between the price level. Even in those prices, what I saw in the presentation was a surprise for me, because we don't have any information, for example, from the market of Congo.
Mm-hmm. Well, we didn't see any Postinor in Congo. That wasn't your product.
Yeah, it was another product.
Yeah.
I agree.
Yeah, it's very dynamic.
But once we supplied UNFPA with a lot of Postinor 2, not in the last year, in the year before, with Postinor 2, and I haven't seen our products on the presentation. But it was a huge amount.
Yes, so those products are in the public sector, and this analysis was really looking at the private commercial sector.
I see.
So we did see a Postinor. In theory, it is in the public clinics, and that's a whole different presentation. We actually didn't manage to actually see it visually in the public clinics, but in theory, it is in the supply chain. Postinor is in the public sector supply chain, but this study was looking at the private sector pharmacies. So that's correct.
Okay.
Yeah. Mm-hmm. I don't know if that's someone trying to ask a question. Obina, did you want to ask your question verbally or type it in?
Hello, can you hear me?
Yes. Maybe the person who's shouting in the background could mute their own individual phone.
Yeah, I think that was Obina. We just couldn't hear her.
Okay.
So I think we will wait for her to post her question to the chat, and in the meantime, maybe we can take the question from MSI.
Okay. Hi, Jason.
Hi.
Sorry. Hi. So, yes, we do have, because it was crowdsourced, we do have some product names and manufacturers, but not for everything. And updating the database, yes. If we had many, many hands on deck, we're constantly trying to get more information into the database. Yes, that's always a challenge. So, and then a really good question that you asked is the lowest price private sector product generally representative of the price point for general access in each country? That would be hard to tell, and I'm wondering if I don't know if anyone is on the line from PSI, and they're doing the sort of deeper market analyses. In some countries, and we probably need to figure out a way to report on this, in some countries there was a huge range from the lowest to the highest, and instead of averaging between the highest and the lowest, we decided to take all the lowest, the average of all the lowest for this analysis, with the thinking that for affordability, the lowest is going to be the most important. But, yeah, the range was really different. And then when you start throwing the ulipristal acetate product into the mix as well, you'll see a really high range from the lowest to the highest. And we know that in some cases the very lower prices are from a socially marketed product, like in Ethiopia, for instance, with the post pill. But it's our data that came in was a little inconsistent, and so we're hesitant to present too much hard and fast. I'll look into our huge Excel spreadsheet and think about if there's ways that we could present a little bit more on the ranges that we were seeing, because I think that is an interesting question. And as I said, in some countries we only had one data submission, so we really would be hesitant to make any kind of statements about an individual country, except for Nigeria and DRC, where we spent time on the ground talking to people, kind of snooping around, going to pharmacies, going to the depots. Really, I would say I'll move over to it. Our slide that's our bar charts that was sort of looking at the regional and sub-regional trends. That would be the result that we're the most confident about. I would say anything for an individual country, you should go double check.
Okay, great. Thanks for that.
Yeah.
So Obina has typed in his comment, which is a really useful comment on the case study in Nigeria. I'm trying to get to the slides. So he's reporting that access to EC for women in rural areas is a really big problem, and that was something that we identified in our case study that we didn't have enough data on. So it's really useful, Obina. Thank you for sharing that. Obina works for Society for Family Health in Nigeria, so he's very familiar with the Nigeria emergency contraceptive market. And I'm sorry we weren't able to hear your comment orally, Obina, because I think that would have been helpful too. But thank you for putting that in. Obina, do you want to try to unmute yourself again? I think it will be most effective if you speak.
I think we actually aren't able to hear Obina. Sorry, Sarah.
Yeah, that's okay. Obina, we can follow up afterwards.
Can everyone read Obina's chat? Because he raises a very interesting point, which I was unaware of, which is the arresting of these patent medical vendors, which seems kind of awful and kind of counter to the law, the way I understood it in Nigeria. So that would definitely be something that we'd like to hear more about.
Obina, is that because of the over-the-counter access law? Nigeria's law is prescription only, but we see a lot of pharmacies and drug shops that will sell it over the counter.
So if you guys wouldn't mind just reading out loud Obina's comments because it's not visible, but
sorry.
No, that's
I
okay.
didn't realize that.
There's a way to broadcast it, but I don't think that's how his chats are going through.
Okay, Obina says, the Nigerian case study was actually okay, but only a few inputs. The last paragraph says rural women access to EC from drugstore. That's where there's a big problem. Rural women can only access EC through patent medicine vendors because they are the closest to them. There is a large absence of pharmacies in the rural areas in Nigeria. But because of policy issues concerning if the PPMVs, the patent medicine vendors, are legalized to dispense EC, authorities keep arresting them, denying the rural women access to EC. The greatest challenge here is that the policy allows them, and the dissemination of that is so important so that PPMVs don't keep hiding from dispensing EC. So I think he's referring to the prescription-only policy that's in place in Nigeria. And there are many, there are outlets where you can get EC without a prescription, but the official policy is prescription only. Obina, please feel free to type more, and we can follow up afterwards as well.
If you choose down at the very bottom I just pasted one of Obina's chats in. If you scroll up and choose broadcast to all instead of broadcast to chairperson, that's the way everyone can see. I did not realize that those weren't available to everyone.
Great, thank you. So would you guys like to take one more question? Elizabeth, Sarah, are you open to?
Yeah, absolutely. I'm glad there was so much interest. This is really interesting work, and it made us kind of eager to learn more.
I'll just read Obina's final note here, which says, in summary, the only access to rural women in Nigeria for EC is PPMVs, and the policy should authorize them since pharmacies are very scarce in the rural areas. Thanks, Obina. This is really, these are great comments. Thanks for your input. Any other questions?
Okay. Well, you guys can go ahead and wrap up. Or do you have any final thoughts from the presenters? Okay.
I think our final conclusion still stands that so Rafaela Schiavone just asked, will we have access to the presentation afterwards? Yes, we can email this out to the RHSC and ICEC lists for sure. We would love to publish. That's always our dream, to have more time to write. So it's always hard to find time to do that once you've actually finished the funding. But yes, we would love to publish. I think this is kind of a new and interesting approach. And definitely, there are ways that you could do it differently and in more detail with a different kind of budget. This was a very small budget. But I still feel like we got this great kind of global sort of regional and sub-regional comparability that I haven't seen before. And it got us to really think about the affordability issue in a different way. I think my conclusion at the end is the same as our conclusion going into it when we wrote the proposal, which is that we really, really, really need this private commercial sector. This is the sector that is out there and providing emergency contraception in most of the world. On the other hand, this issue of new products coming in and not necessarily being of known quality is also, the more time we spend out there, and we always go to pharmacies and we always look and take pictures of everything that we can find, we're seeing more and more products that we are unfamiliar with. We read the packaging. We don't know who the manufacturer is. So I think, this issue of this very, very dynamic, fairly unregulated global market for levonorgestrel is something that we're continuing to see. Alison Bodenheimer asked if we could share the slides in French. We have not translated any of this work into French, but let's look into that. And Justice from Uganda asked about the life-saving commodities and how EC is definitely one of the life-saving commodities, and that in Uganda, EC would be assessed through village health teams. So we'll definitely be in touch to talk more about the Uganda situation, which is also, there's a lot of dynamic growth and change there as well. So, I mean, in conclusion, I think this is changing every day. We could probably go back out next year or this year and get, slightly different and equally interesting information. So any final thoughts or questions from the group?
Denise, did you have a comment you wanted to put out there?
Denise had a comment.
I think Denise may have issues with unmuting her line. We're not able to hear her right now. So she'll send it to the listserv. But I wanted,
you can, or you can, if you can quickly type it in, we could read it out loud, but I think we just have a moment left.
Okay. In all of this, Denise is just reminding us that it's important to remember the manufacturer and that market sustainability is critical. So when we look at pricing, to ensure that the costs of the manufacturer and a reasonable margin are taken into account. I think that also definitely drives potential questions around quality. If we drive the prices too low in the market, we could be incentivizing lower quality products to be placed out there. And then in addition, there might be a crowding out of the commercial sector, meaning less innovation and sustainability if we give out a lot of free products. So I think what she's trying to say is the market segmentation part of the total market approach is very critical, that we're trying to ensure that the lowest priced products are getting to the women who have the least access and the least means to afford them. So going back to Deepa's point at the beginning of the question session.
Absolutely.
Yeah. So Elizabeth, do you think maybe we should wrap this up and we can take additional calls on March 30th at our next MDA working group call?
That would be great. And we've taken note of all the questions that came in the comments via chat, and we'll follow up individually with a few folks. Thank you so much for your close attention and for all the questions and comments. And yes, we can discuss this more at the next MDA call as well, if people want.